Good afternoon. This is Kevin Flaherty. I'm a pulmonary physician at the University of Michigan and work with the Pulmonary Fibrosis Foundation with the Care Center Network and Registry. And it's my pleasure to welcome you to this Pulmonary Fibrosis Foundation education webinar, Cough 101, an overview of cough and pulmonary fibrosis. It's my distinct pleasure to introduce my friend and colleague, Dr. Greg Cosgrove, who's the Chief Medical Officer for the Foundation and a physician at National Jewish Health, who is going to lead the discussion on cough in pulmonary fibrosis. Greg, thanks for your presentation in advance.
Thank you, Kevin. It's really exciting to be here and to touch on a topic that we really have not discussed in any form before, but I know you and I both try to address it with our patients on a weekly basis because it's so common. So it was really driven by the concern from a lot of patients and family members and has a tremendous unmet need in terms of how do we address cough in patients with pulmonary fibrosis. So that's really the reason behind this educational topic, and hopefully it'll be the first of many as we better understand that really troubling symptom. But what I was hoping to accomplish today is to address some important aspects of cough in patients with pulmonary fibrosis, meaning the significance of it, and describe what we know, how frequently it occurs, and what it is associated with. And then perhaps begin to try to understand the mechanisms of cough in general, and perhaps why it's such a common symptom in pulmonary fibrosis. And that will lead into hopefully understanding better ways in which we can begin to treat cough. Certainly there are options, but the evidence behind treatment for cough, particularly in pulmonary fibrosis, has been limited, likely due to such a complex problem. But there are emerging trials that really are seeking to guide us and evidence the treatments that are potentially available for patients. And lastly, to try to facilitate those studies, talk about some new tools we have at the Foundation that can be used to help patients and caregivers identify resources as well as potential participation in clinical studies, and really trying to drive and accelerate the evaluation of interventions. And so I'd like to maybe start off with a case that exemplifies the problem. And this is of a gentleman who really was troubled by a cough for 6 months. And he actually indicated it was worse at night, but the cough was 24/7 and really limited his activity and frankly, quality of life. And his examination really was consistent with pulmonary fibrosis, and his CT image on the right-hand side of the slide ended up being consistent with a usual interstitial pneumonia pattern. So we diagnosed him with idiopathic pulmonary fibrosis, but his question drove a lot of the information I've tried to acquire for this presentation is, why do I have a cough and how can I treat it? Because it was quite debilitating for him. It led me to try to maybe better understand cough in general. And certainly cough is really common throughout any one of our lives. But we can break it down into really causes, and that would be an acute cough, which we all probably have had recently over the past year related to a viral type infection, typically lasts less than 3 weeks. Maybe in predisposed individuals who have a sensitivity, their cough lasts a little bit longer, and the reasons for a subacute cough, which is 3 to 8 weeks in duration, are slightly different. But I guess what we want to focus on today is chronic coughs. It's something that's been going on for at least 2 months. And in our clinic, and I'm sure yours, Kevin, that the vast majority of patients have cough, and we speak in months, if not years, in contrast to weeks. And so it kind of sets the stage of where we want to move forward in this discussion. And so this is really complex, which I think is why we don't know as much about cough, even though it's such a frequent symptom with a lot of diseases. But I've tried to demonstrate here some of the basics, which are pretty complex. But we know that when you have a cough, there are actually chemical or biologic mediators, things like histamine or substance P, or ligands to certain receptors adjacent to the airways and affect the nerves in the lung. And when those nerves are stimulated, then they can initiate what's called a cough reflex. And so it's a combination of a circuit between the lungs, the nerves in the lungs that feed back into the brain, and then the brain initiates a reflex of a cough. And so it's a pulmonary neuro circuit, and abnormalities in any of that circuit can cause a cough. So at least mentioning that is really to help you understand it's pretty complex, but it also means there's opportunities to intervene and shut down that reflex moving forward. What we do know is that when things in the environment change, and I have the next slide will document this a little bit better, but it can affect the nerve fibers in the lung or different aspects in the nerve fibers, such that perhaps if you have inflammation in the lung, it lowers the pH and then increases the sensitivity of the nerve fibers to irritation. And that can happen with allergic inflammation, or perhaps also tobacco smoke changes the sensitivity. So they're almost hyperactive to respond to irritation. And lastly, in addition to the chemical irritants and environmental changes, we know that when the lungs structure is altered, so if you have a pneumonia where there's inflammation and infection in a portion of the lung, or a viral infection that changes the structure of the lung, that mechanical irritation can initiate a reflex within the lung. And so these are at least three different examples where changes in the normal function of the lung and the airways and the nerve fibers and the milieu result in cough. And so this is really a great slide that I found from almost 7 years ago now that really talks about triggers that can cause cough. So things in your environment, we talk about perfumes and abnormalities with chemicals in the environment that can irritate different parts of your lung. And what I'd like to emphasize is when we think of cough, it's just not a problem within the lung proper, but this is to represent the vocal cords here. And then we have the large airways. And then as we go down, the smaller airways. And so abnormalities in these areas of within the lung or associated portions of the lung all can be complicit in the development of a cough. And to compound that, we see that there are different cough receptors within the lung that are responsive to different stimuli. And so really emphasizes, particularly perhaps in asthma patients, where we really try to understand the triggers of their disease, because it's considered oftentimes a large airways disease, and there's cough equivalent asthma. But the last part of the slide is to really demonstrate that it really is a feedback loop and a reflex, in that it's just not a problem within the lung, but it's coordinated through the brain and initiates the cough in response to irritants. And so not to overemphasize it's complex, but it also suggests there are multiple ways in which we can intervene and hopefully help patients moving forward. So that's kind of a general background for cough and maybe some of the important mechanisms. And I don't mean to simplify it, and it's much more complex than perhaps I've suggested, but it's a great setting, or at least introduction to this presentation. But if we maybe talk about what we know in patients who have IPF, and I'll use that as an analogous disease for other fibrotic lung diseases. And so I don't mean to exclude them in this presentation, but a lot of the concepts and features are very similar. Unfortunately, we just don't have a lot of information in other fibrotic lung diseases outside of IPF in general, and in particular for cough. So, but I don't think that you should take that as this doesn't apply to your disease, perhaps if you have chronic hypersensitivity or if you have scleroderma-associated interstitial lung disease. I think it's still relevant. But what we know about cough and IPF is, first and foremost, it can be the first symptom anyone has of an underlying interstitial lung disease. And oftentimes, preceding breathlessness by months to years. And so it may be an early warning signal. We have a campaign that really is focusing on cough and more than just a cough. And something that we really want to alert people to when you have a chronic cough. It is something that should be investigated. We know in patients who have IPF, close between 70 to 85% of patients with IPF have cough. And very exquisite studies that were done in as early as 2003 by the group in the UK documented cough and did 24-hour monitoring of patients. And we actually saw in patients in which we believe the cough was directly associated to their IPF, it was more common in the day than it was at night. And it didn't appear to awaken patients if the cough was directly related to their IPF. And what I hear, and I'd be interested to hear your thoughts too, Kevin, is that oftentimes it's a family member saying, gosh, my brother, every time I talk to him, he's coughing on the phone. Or when they exercise, they're coughing on a regular basis. Is that something you hear from your patients as well, Kevin?
Yeah, very frequently. And kind of related to this topic, there was a good question that came through that was actually asking about why is the cough worse at night? And so I'm wondering your thoughts on that. I mean, certainly there are people that may have cough worse at night. Do you think that might be that there's a different mechanism driving that? Like, I think you're going to talk about, other contributors like reflux and things. If the cough is worse at night, that there might be a reason to see if there's something related to that. Because certainly my experience, and as you point out, the IPF or interstitial lung disease cough does seem to be worse with activity and during the day than at night.
Well, you set me up nicely, Kevin, as well as the question from the audience. That was my next point. And I used
the audience.
In this specific case, and why I chose that presentation from one of my patients, that cough is multifactorial, and probably up to 50% of patients, cough is attributable to other reasons, such as postnasal drip, upper airway cough syndrome, or reflux, as it was in the patient I presented. And so when you see differences, I think we can use the information that Ben Hope Gill had put forward about the features of cough directly related to IPF, and it drove me to say, well, if he's having symptoms at night, is there something else that he's that's driving his cough? In the case that I presented earlier, it was because he had very significant reflux. What we do know is it's important to treat other causes of cough moving forward, which I mentioned as refluxes, but asthma is very common in the general population. So you can have an uncommon disease, IPF, and asthma. And so we should remember to think about that and treat asthma if it's present, or bronchitis in patients who smoke or have COPD, since a large number of patients, at least with IPF, also have prior tobacco exposure. And really a lower hanging fruit is anytime I see someone with cough, I look at their med list just to make sure, because some of the medications, in particular antihypertensive medications, ACE inhibitors or angiotensin receptor blockade inhibitors, can interfere with some of those mediators like the histamine circuit as well as bradykinin, and they can unto themselves increase a cough. So I think thinking about all the potential other diseases that can cause cough and appropriately treating them is important. But the cough rarely resolves completely if it's attributable to the IPF. But certainly any way we can improve cough is really important. But what I'd like to focus on, is in addition to those comorbid conditions, is focus on the cough related to the underlying disease and interstitial lung disease. So hopefully that answers the question. And how it affects each and every other patient who may be listening, that's really a conversation you should have with your doctor. And what else could we do? And that's kind of the point of this presentation. And I guess in the past, and maybe in the general public, when people think about cough, they think it's certainly uncomfortable, certainly annoying to see how it affects the person who is coughing, but it's more than just a cough. And what I mean by that is it really affects patients' quality of life. And in severe cases, it can lead to social isolation. And you say, well, why? Well, if you're coughing all the time, you can end up coughing so much that some patients cough vigorously with that dry cough, and they can actually almost, they have post-tussive emesis or vomiting. The cough is so severe. Fortunately, that doesn't happen very frequently, but you could imagine if that's a fear of yours or the fear of having incontinence related to a severe cough, it doesn't really engender a robust interest in going out and being amongst friends and others if you're always worried about how the cough is going to be perceived or perhaps how it's going to affect you physically. So addressing it's very important.
And yeah, I think that's a huge point. You know, people are always, I know when I have, cough from a bronchitis or something and I'm out and you can just feel people, kind of looking at you like, are you contagious and why are you here? And it can be very, very, very isolating.
And that's a really good point, Kevin. I also with that is the cough in IPF isn't contagious. And I think maybe that's what we need to get out there to the general public. There are so many other causes of cough, but that social isolation could extend to that, especially during flu season, I guess, too. Sure. The group at UCSF and others, Brett Lade was able to demonstrate and follow patients who had cough. And it's not just debilitating socially or from a symptomatic standpoint, but it really can be a marker of how severe one's lung disease is. And if the cough is progressing and it's not related to some of the other comorbid conditions, it suggests or it may suggest the disease is progressing. So not just cough as a symptom, but it might reflect an underlying progression of the lung fibrosis. So something to really follow longitudinally and address with patients and use it in concert to other techniques like the pulmonary function test and CAT scans moving forward. And maybe this is, so why is cough so prevalent in patients with pulmonary fibrosis? Are there differences between those patients that result in cough and perturbate those mechanisms we talked about before? Well, the answer is yes. Patients who have pulmonary fibrosis appear different. And they have an increased sensitivity in their cough reflex, meaning that the common irritants that would result in cough in anyone, a much lower dose of that irritant will initiate a cough in patients with idiopathic pulmonary fibrosis. They appear to have a change in some of the hormones that are related to the nerve fibers in the lung. And those nerve fibers are therefore not only increasing sensitivity, but maybe primed to respond to a cough initiation. And there's been some data that suggests that abnormalities in the mucus of the lungs of patients with pulmonary fibrosis may initiate a different mechanism of cough and inflammation. And lastly, if you remember back to the CAT scan I showed, there were some abnormalities, the extra lines in the lung. And what we talk about is the scarring in the lung causes distortion of the airways, what we call traction bronchiectasis. And there's some thought that distortion of the normal structure of the airways, where the nerve fibers are, that mechanical force can stimulate those nerve fibers, and perhaps why cough becomes more common as patients have more progressive lung fibrosis, because perhaps some of that mechanical change within the forces in the lung change and is associated with cough. So all these areas we need to better understand. We need to investigate ways in which we can ameliorate those differences, and then hopefully identify better treatments to help patients. And so this is maybe just a summary diagnosis or schema that talks about that, or what I had just mentioned. And it perhaps better helps you understand that the more abnormalities as the disease of pulmonary fibrosis progresses, it begins to affect the nerve and cough fibers and receptors within the lung. And so that's really where we want to move forward. And the end result of those changes is that dry, hacking cough. And that tends to be more related to IPF. And I think one of the questions at the end that I'll address now is, well, what if you have a a wet or productive cough and you have idiopathic pulmonary fibrosis. Well, I might suggest that if that is occurring, perhaps there is more than one reason that you're having cough. So in someone who's a smoker and has IPF, perhaps they have chronic bronchitis variant of their COPD, and we need to address that cough possibility in addition to what's going on with their lung fibrosis, or could they be having significant reflux? And so it's another example of using what we know about IPF, how the cough is initiated in that particular disease, and understanding the differences when patients have slightly different symptoms than, quote unquote, the common cough in IPF.
So, Greg, I want to get your experience, because one of the things that I see is that sometimes a cough that initially is more dry and typical of IPF, and as things progress and more scarring ensues, that often later on that cough can turn productive. And I'm curious if you've seen that. In my mind, I've wondered about more development of traction bronchiectasis and architectural distortion leading to more mucus production and the change in the cough. But I'm curious if you've seen that as well in your patients, or maybe it is just that other things are developing, or could be a combination.
I think it's the latter. There's probably a combination. I always, as you do, look for the things that we can prevent or take care of, any new changes, because it's such a dynamic disease. But with some of the emerging genetic data that there are abnormalities in genes that are involved in mucus production, and that mucus does become more common in the distal airways and in the airways itself as the disease progresses. I wonder, could that be changing the cough, and is that why it is a little bit more productive? But I don't know if we know the answer to that, but I share your concern that the disease we know is pulmonary fibrosis is not static. It changes over time, and we just need to know more.
Yeah, I agree.
And so maybe going back to the second question that my patient posed to me is, how do I treat cough? Or how do you, is what he said to me, how are you going to treat my cough? And I don't have a lot of definitive answers yet, but there are pathways to move forward. And this is maybe a paradigm that I use. And Kevin, I'd love for you to share any thoughts you have and how you treat your patients. There are guidelines for cough and multiple iterations, cough in general. At the CHEST organization, they have an annual statement so that addresses cough in all diseases. But this is more focused in pulmonary fibrosis. But I think first and foremost, since cough is so common, I look for the comorbid reasons for cough and treat them appropriately. Then I think about treating the underlying disease, meaning the cause of the pulmonary fibrosis. And then the last part is, are there specific therapies for cough related to pulmonary fibrosis? So treating the cough specifically rather than the underlying disease. And we'll talk about that. But this is a really wonderful summary slide from the group at Hopkins and Maureen Thornton, who had put this together and has an interesting cough. And what I can say is there has been interest, but in contrast to maybe looking for the antifibrotic efficacy in different agents, it's been somewhat limited. And there have been smaller studies looking at the role of anti-inflammatory therapies, things like prednisolone or prednisone, more commonly in the United States. And there are oftentimes small studies that have a suggestion of improvement, and they advocate that perhaps it decreases inflammation in the anti-inflammatory group. There are some two studies that look at actually one of the antifibrotics that may have anti-inflammatory therapy, pirfenidone, that appeared in a retrospective analysis to decrease cough, and then also in an observational cohort that there was a change in the cough. And some very small but interesting work looking at a cytokine called interferon alpha looked at patients and showed a reduction in severity of cough using a novel anti-inflammatory therapy. And then probably the most studied agent over the past 2 decades has been thalidomide, and actually proceeded at the group at Hopkins to a randomized double-blind study, so a robust study and multi-center, to begin to understand if it has anti-inflammatory study effects and can suppress cough. And I'll speak to that a little bit later in more detail. And then lastly, perhaps the role of treating reflux, so decreasing one of the initial irritants. So certainly work has been done, but I think we certainly need to better understand cough more and identify better treatments moving forward, because it is such a common symptom. But more to make sure you're aware that work has been done in the past, but we certainly need more randomized controlled studies that prove not only safety but also efficacy, so that we more aggressively define the best treatments for patients with pulmonary fibrosis and those that treat cough. And so this is how I begin to think about the flow of treating cough in my patients. And I would argue kind of a standard approach in the field is, since reflux is very common in individuals with pulmonary fibrosis, and some people estimate 80 to 90% in patients with IPF, it is something I look for on a regular basis. And many patients say, well, how can I have reflux? I have no symptoms. Well, that's because between only 25 and 50% of patients will have symptoms of reflux, even though we can prove they have it. And treating that may or may not modify the cough. In the patient I presented earlier, that individual had significant reflux up to the level of their clavicles. And so every night when he was lying flat, I think that stimulated a portion of his cough. That doesn't apply for everyone, but I think a general approach of modifying behavior, not eating right before you go to bed, and then talking to your physician about the role of reflux in cough, but also in pulmonary fibrosis. We know that there are some studies that advocate that treating reflux may benefit patients with pulmonary fibrosis independent of their cough. Still, work needs to be done moving forward, but it really is suggesting that just as cough, it's not just a simple symptom. I would say reflux is not just a simple symptom either, and it may be driving the disease in ways we don't understand.
Greg,
yeah,
curious, so with a high prevalence of cough, but then a low proportion of those with active symptoms, what is your approach to diagnosing if reflux is there or not? Can you describe the tests that have to be done to see if reflux is there? And do you think it's important to do that before just empirically treating?
It's a really great question. And this certainly is, I'll give you my opinion and also maybe some of the evidence, and you could comment on the guidelines from ATS since you're involved with their development, but certainly asking patients first and foremost, and not just asking if they have reflux, but going through symptoms at night, during the day, and trying to be as meticulous as possible. But I oftentimes will pursue a swallowing study or an esophagram to look at whether or not there is reflux, even if patients don't have symptoms. I think there's evidence that could be helpful in some patients, as well as a pH probe some individuals use to monitor. That's helpful when there's acid and it can be detected, but it doesn't necessarily identify what we call non-acid reflux, which is very common as well. So, and we still see it in patients who get treated. So I think there needs to be a high index of suspicion because it is so common, but certainly we need more information to figure out the best pathway. How do you, in your group that you treat, evaluate reflux?
Yeah, very similar, from ranging from esophagams to, 24-hour pH probes to really, try to quantify how much is there, particularly when there aren't symptoms to suggest that reflux is going on.
And maybe you might comment on, since you were involved in some of the studies, that there have been a lot of attempts to understand treatment of reflux and its impact in pulmonary fibrosis. Could you maybe share that with the group?
Yeah, so when we talk about the pathobiology of pulmonary fibrosis, we think of it as an abnormal wound healing model where there's been some injury, and in the right environment, that injury, instead of healing, leads to progressive fibrosis. And there's been a lot of talk that perhaps one of those injuries could be reflux. And in a small phase 2 trial that was published recently called the RAP study, that was a study, sponsored by the NIH, that looked at patients who had a 24-hour pH probe that had IPF to document they definitely had reflux, and then they were randomized to either getting surgery, Nissen fundoplication, versus medicines, with the hypothesis being that the surgery could prevent not just acid like the medicines, but other things that could be reflux like bile or pancreatic juice, and may do better. The study was, for a primary endpoint, the change in lung function was overall negative, although there was a trend towards slower decline in lung function in the people that had surgery. And a lot of the secondary endpoints, like categorical changes in lung function, like drops of 10% of lung function or exacerbations or transplant, those were actually statistically significant in the surgery arm. So it was a negative study, but it had a lot of positive features to suggest that reflux may not just play a role in cough, as we're talking about here, but may actually be something that may be involved in the pathobiology of the development or progression of pulmonary fibrosis. So hopefully that'll lead to future, more definitive studies, since it was a smallish phase 2 trial and was technically negative.
Okay. And it really emphasizes we need to better study these complex issues, and it speaks to maybe the last comment onto the treatment, is that there are some medications, that neurologic medications that may be beneficial and have been used but not studied, that I really only use in concert with my gastroenterology colleagues. So patients with refractory reflux with persistent symptoms despite aggressive treatment, then utilizing novel medications. But I would say that's a tertiary agent after I work with my colleagues. And as I think we talk about, it's always better to get more input in complex diseases. And I would say that just as we work with other members of our own group with multidisciplinary approach in the diagnosis of patients with IPF and pulmonary fibrosis, the care needs to be multidisciplinary. So with severe reflux, having input from a gastroenterologist, or with severe other aspects of the disease, getting as much expertise to guide care, I think is really important until we have definitive evidence moving forward. And I think that was the great example in the RAP study, that it was a combined group of individuals caring for patients with pulmonary fibrosis, not just quote-unquote lung doctors. So as we move forward, certainly just, again, remembering cough can be common, and I guess low-hanging fruit, quote-unquote, is not to forget that patients with pulmonary fibrosis can have emphysema, and we have, or COPD, and we have medications that can really improve symptoms with inhaled therapies, both for COPD and asthma. So it's just always something in the back of our minds. We need to not forget common diseases are common, and we should not miss the opportunity to treat them appropriately. So what about moving to the next part, is what if we treat the underlying pulmonary fibrosis? Is that going to help cough? And the answer is we think it might. It makes sense if you use the paradigm that if there's progressive fibrosis and there's architectural or mechanical distortion of the lung, that distortion or stimulation could increase resultant cough. And so there has been, as I alluded to before, some work that's been done where retrospectively looking at the trials for pirfenidone, and retrospectively identified that in those that were treated compared to the placebo group, that there appeared to be a decrease in cough and a decrease in symptoms. Again, it's retrospective, but it suggests that perhaps if we treat the underlying fibrosis, perhaps the progression of the disease, as we know, is decreased, and perhaps that can modulate the cough. It may not make it go away, but it certainly could, underlying could make the cough be less progressive. And so that's something that certainly we should think about as newer treatments are being evaluated for pulmonary fibrosis. And I would argue that cough is such an important symptom that perhaps it should be one of the secondary endpoints, and it appears that that's becoming more common as we move forward. And so I think it's important for us to think about that, but maybe probably what everyone's waiting for is, well, how do you just treat the cough itself? How do we move forward? And are there specific therapies to get rid of this cough that I have? The answer is we have therapies, but I don't know if we can say we have a definitive proven therapy. There's been a lot of work that's looked at how do we suppress the cough, so block that reflex and inhibit the receptors inside the lung. And you see on advertised regularly, so cough suppressants, like dextromethorphan. There are also medications like gabapentin that, again, is a medication used in neurologic abnormalities such as paresthesias in the hands and feet, but it affects the nerve fibers in certain ways, and perhaps that has some efficacy, although not definitively studied. But for many years, medications have been attempted, like amitriptyline, opioid medications like codeine, and then there are novel agents such as the P2X3 receptor inhibitors that block more specifically, with perhaps less side effects, certain receptors within the lung. And then more recently, some of the opioid-like medications like nalbuphine that may benefit patients. But the question that I often get asked, well, is it proven to be helpful? And the answer is not right now. The studies just haven't been done in patients with IPF yet, but I'll show there's an emerging interest to really define the best treatment and understand cough in IPF.
I think it's important to highlight that they really haven't been studied well, and even knowing the safety profile, because a lot of these neurologic medications can have side effects, and so it's worth realizing that this does need, as you're highlighting, a lot more study to understand, is there benefit and is there risk associated with that benefit?
It's a really good point, Kevin, and I don't want anyone listening to think that these are quote unquote the best treatments, the antitussive medications, but it really needs to be a discussion, as you allude to. Is there a potential benefit, and what are the potential side effects, until we have evidence to say that which treatment is best and which treatment works. But until that time, you really need to have that open discussion with your physician to find out what regimen might be best for you as a specific patient. One of the aspects that sometimes gets forgotten, and I alluded to it a little bit, in that there can be cough stimulation in the upper airway, so around the vocal cords or other aspects in the swallowing mechanism. So there is evidence that in certain patients, behavioral therapy, swallowing techniques, and also individuals that have such a severe cough, they actually can precipitate an ongoing cough, the way in which they're coughing and irritating their vocal cords or the vocal cord apparatus. So speech pathologists can have a role, and that is a behavioral therapy rather than medication. And the last group that I'll touch on a little bit more is what we call anti-inflammatory therapy. So we talked a little bit about prednisone before and the interferon alpha. I'll spend a little bit more time on the two medications that have been studied in patients with pulmonary fibrosis. And the first is thalidomide. And it was originally studied almost more than a decade and a half ago in a small group of patients, in which we saw some benefit. And then it led to a randomized clinical study, which was placebo-controlled, and with the lead group at Hopkins. And thalidomide, you may recall, has a fairly notorious history. It was used as a sedative in pregnant women in the 60s and 70s, and unfortunately had significant predisposition to birth defects. And so it was quickly removed from the market. Unfortunately, not quick enough because there were many individuals that suffered problems related to it. But emerging evidence shows that it really affects the immune system in certain ways that we don't understand, but it modulates the immune system. It has anti-inflammatory and anti-angiogenic, which means affects the blood vessel growth. But in this novel therapy that was driven by very preliminary work, they actually, in individuals with pulmonary fibrosis, were able to identify a significant improvement in cough and an improvement in the sense of quality of life and in breathlessness. So it's depicted in this slide here on the panel on the left, in which thalidomide was used, and we see a downward trend in the number of cough events that are occurring and a downward trend in breathlessness, so improvement in both aspects. And on the right panel of graphs, you see that individuals who were then taken off and placed on placebo, that trend reversed. And so it is a suggestion that individuals were responding to the treatment. But what is clearly evident, as we've seen before, there were a significant number of side effects, with almost 74% of patients receiving that medication having side effects. And so I don't think, number one, it's not readily available because of the severe side effect profile and the prior complications with exposure to anyone who is at risk or pregnant. It does suggest, and what I think is maybe there are novel formulations that affect that pathway that have less side effects moving forward. So it's an insight into ways in which we can perhaps better treat cough moving forward. I personally have not used thalidomide because of the side effect profile, but I'm encouraged to see that it's suggesting we can modify cough in patients, but we need to identify perhaps better medications with less side effects. Do you have any experience, Kevin, with thalidomide in clinical practice?
I would just concur with your thoughts. I have not used it either because of the difficulty with accessing it as well as the side effects. But it is encouraging to see that when you do well-controlled studies, you can see that the cough is treatable. And so I think it gives me hope that future studies and ongoing studies that we'll touch on in a little bit, can show an effect on cough independent of treating the underlying disease.
Yep, exactly. And maybe that leads us to I think, some evidence that going back and then looking at medications that we used perhaps 10 or 15 years ago and thinking about how they might have a role in other aspects of different diseases. So cromolyn sodium was a medication that was used in asthma before we identified things like albuterol or inhaled corticosteroids, and it provided some benefit for patients with asthma. But through a lot of hard work by basic scientists and such, that the concept of could it be used to affect the hormone milieu within the lung and stabilize some of those triggers of cough. And a group subsequently put forward a study using inhaled cromolyn in patients with IPF. And the compound was termed PA101B and is now relabeled RVT-1601. And so it's an inhaled compound. And what the panel on the right suggests in patients who have pulmonary fibrosis compared to a placebo group who did not receive that compound, who also had pulmonary fibrosis, that within 7 days and also at 14 days, there was a significant reduction in cough in those that received the inhaled mast cell stabilizer, cromolyn sodium. And in all honesty, we don't exactly understand all that the medication does, but it certainly appears to modify cough in patients with IPF. And it didn't appear necessarily to modify those who have cough related to a non-IPF reason. And so in my mind, I'm looking at this thinking this could be a more specific treatment for patients with IPF who have cough. And it's encouraging to see these preliminary data moving forward. And what I would suggest is as a result of this, there is an additional trial that is now enrolling to better assess this, to make sure that the safety identified in the original small study continues, and as importantly, that we can prove that in a larger group of patients, this therapy affects cough as it was suggested in the preliminary phase 2 study. And so I might dovetail into that, because I actually think the way we're going to answer the questions that Dr. Flaherty raised about, the insights that we saw in thalidomide, or the insights that we're now seeing in cromolyn sodium, how do we get the final answers? And I think it really comes through participation in clinical trials. And so to try to enhance that and to really demonstrate the hope and the number of people working in pulmonary fibrosis to try to identify treatments to help patients, not just with cough, but all the other aspects of the diseases, not just for IPF, but other fibrotic diseases. We do have a new set of resources to help you. So if you go to the Pulmonary Fibrosis Foundation website, and then go to Life with PF, and then toggle down to the Clinical Trials Education Center. So in doing that, you have two different resources. One is a new pipeline, which lists all the active trials being explored in patients with pulmonary fibrosis in the U.S. and throughout the rest of the world. If you want to more directly assess trials, and particularly trials that are around you at home, there's also a trial finder. We'll access the trial finders through the pipeline moving forward, but there are also educational information about clinical trials. So it gives you the differences in trials, why we're doing different things moving forward. But if we click on the pipeline, I think I look at this as a depiction of tremendous hope for our field. So if we look down, and I'll toggle down, for patients with idiopathic pulmonary fibrosis, we see it lists all active trials, and they can be phase 1, phase 2, phase 3 trials. We see that there's tremendous interest in identifying and evaluating therapies for patients with idiopathic pulmonary fibrosis. But I would also argue in patients who have had transplant for various fibrotic lung diseases, there are novel therapies that are being investigated. And I think this is different than when Dr. Flaherty and I started. There weren't any significant trials in other forms of lung fibrosis. And we see an innumerable number of studies looking at different agents to try to understand their role in the treatment of specific other causes like scleroderma or chronic hypersensitivity, or in other aspects that accompany pulmonary fibrosis, like pulmonary hypertension. And so although that aspect is really important, and this allows you to look at the different things that are going on, I'll use, since we're at the chronic cough lecture, let's go to chronic cough and check. So here, as I mentioned, there is an evolving trial looking at cromolyn sodium. If you click on that legend there, it now provides you additional information, and this is available for any of those trials listed in the pipeline. So you can better understand what the trial is investigating, so an inhaled formulation. You can understand the study purpose, and this information is culled from the clinicaltrials.gov. And so unless a study is registered, they wouldn't appear in this compendium that we incorporate all that information from. So it gives you a pretty quick answer as to why is the study being done and what are the goals of the study. We actually have information that any new information that's released by the sponsor of the study or that comes out, such as publications, will be here as well. And if you're like my patients, they say, that's great, but how do I enroll? Well, another way to access the clinical trial finder is to click here. And so for this specific study, it will come up. You can actually put in your zip code, and it will direct you to the closest study to you, but it provides information about the eligibility. So who can participate? Is there any gender differences? And you can actually toggle down with even more specific information, because to have successful trials, the patients that can be included sometimes is limited. How early is it? It's a phase 2 study. Who's the sponsor? Who's the primary person responsible for the study? And are they recruiting yet, or is it already closed? So in this case, the cromolyn sodium study is recruiting. And then we actually list all the active sites. So you could actually go check if you happen to be in the Seattle area. You could check and find out who's the site coordinator in your area and how do I contact them through the company. Occasionally there's a direct number to the site itself. So I think this resource allows patients and family members to have much more access to what's going on in the field and participate moving forward. And I think from the foundation standpoint, it allows us to, I think, better serve you. So number one, you understand and can get information as quickly as possible. And for those that want to participate, we try to make it as easy as possible moving forward. So I would encourage you to maybe go to the website and look at different things you may or may not be interested in. But at the end of the day, I think this is a list of hope in my mind, because there are many studies in here that if we have 2 or 3 more treatments for patients with pulmonary fibrosis in the next several years, I think that would be fabulous. And certainly there are many people trying to help patients who are affected by the diseases moving forward. So I'm going to minimize that. And then maybe move forward into some of the questions. And Kevin, I think we might have answered some of these in the talk in general. I know we have a few minutes left. But maybe I'll tackle the first one. What are some strategies or breathing techniques that could help control a chronic cough? It's a tough one. I would say I work with my speech pathologist and help patients breathe more effectively because sometimes they develop an abnormal breathing pattern, but it's a little bit challenging because I really try to help patients be as active as possible, but depending on the stage of their lung disease, the more they exercise, the more they may cough. But there are certain ways that the respiratory therapist and speech pathologist can teach you to breathe better and less stimulation, but still allow you to exercise. And so I oftentimes have a comprehensive evaluation in respiratory therapy to help patients identify those strategies. So I might encourage you to do that. As Dr. Flaherty alluded to, a lot of these techniques are certainly helpful, but we really haven't done comprehensive studies. But the risk of doing them are relatively low, and in certain patients it does help them. So in the right patient, I think it can be helpful. Excuse me. And I might take the second one too, Kevin, because we kind of addressed this with cough, and does it mimic or does it have some prognostic value that perhaps cough not only reflects an underlying disease, but in certain individuals, it can reflect progression of disease. And so it's not just a symptom. I think it's a marker of disease process in pulmonary fibrosis or multiple different diseases. And so by treating or trying to treat cough, I think we can help patients, but it's not just a symptom in my mind. And I think we probably answered the third question here as well in the talk, as well as the fourth. I think we alluded to the role of gabapentin. Do you have any comments about that, Kevin, and the role of Neurontin in the treatment of cough in your clinical experience?
Yeah, so my limited experiences, I've not found it been beneficial. But as we talked about before, there is potential, and what really needs to be done is our well-controlled trials to see if there are patients that might benefit, and then balancing that with the side effects of these types of medications. So it's not a medication that I commonly prescribe for cough with relation to IPF.
It demonstrates that there are important scientific hypotheses that where we think modifying what we call the GABA receptor, which these two medications affect, have a potential role in cough. But just like we see that in other aspects of the pulmonary fibrosis, not every patient is the same, not every patient's course is the same. So the only way we can identify the role of any therapy is to study it more aggressively. And I think it still is an area of promise, but we certainly need, as you mentioned, better studies to understand who is the right group to benefit from any treatment. We actually went through a lot of these questions, and this is an interesting one, and it speaks, the second one, the cough associated with non-IPF diseases. And I think scleroderma is one that is quite challenging because it has multi-system effects where individuals with systemic sclerosis or scleroderma, it affects the lungs, it affects the thickness of the skin as well as the esophagus. So they tend to have significant abnormalities, not just with reflux, but with the function of the esophagus. And so addressing reflux, but also other aspects of scleroderma is important. In several scleroderma studies, one of which was called the study looking at, the scleroderma lung study looking at a drug called mycophenolate, which appeared to modify the progressive fibrosis. It also appeared to impact cough. And so it's a great example of when we begin to study certain diseases and move forward, you can see differences or identify potential therapies. But again, I would say the evidence base for directed treatment in scleroderma has to be discussed in each and every patient because each and every patient in that disease can be quite different from another. Really kind of emphasizing and why we put in the pipeline and the study finder in this talk to really try to ask for your help so that we can better answer these questions and much more specifically. And Kevin, I don't know if there are any additional questions from the audience that have come up while I've been speaking that we should address. Do you see any on your list?
Two related questions, and I'll get your thoughts. And how do you approach either ongoing or recurrent cough in someone that has pulmonary fibrosis and had a single lung transplant? Do you approach that differently, or do you go through the same mechanisms that you would for any cough or cough with IPF, thinking that perhaps it's due to the native lung, or is it something going on in the transplanted lung?
Boy, that's a great question. I think first and foremost, it needs to be a discussion with the transplant team as well as the pulmonary team, if they're not the same group. In Denver, where I practice, I do not routinely care for patients during their transplant phase, but they're pre-transplant. So I enlist their help. I think it could be there are more potential causes of cough in that group of individuals. And I worry, given the number of medications that they could be on that suppress their immune system, I always get concerned about the potential for infection driving cough as well. So I think it's a combination of, I think of everything we've just talked about, but then I also think what else could be, because they're quite a different patient from the pre-transplant patient till after transplant because of what's occurred. I might throw that back to you too, Kevin. What are your thoughts, since I know you do care for transplant patients as well?
Yeah, I would concur with what you had said. I worry about all the things that you covered through this presentation that can treat cough outside of IPF and people without a transplant, and then adding in those extra things such as infections or complications from the transplant that in addition could cause cough. So it really is going to require, as you point out, a very thorough evaluation both by the transplant team as well as the pulmonary team if they're not one and the same.
Yeah. Well, I think maybe we might have to end there, Kevin, but the other question we can certainly answer offline and provide with the online component of this. This will be an enduring educational series that patients can download, and that'll occur over the next several weeks. And any unanswered questions we'll address and provide in the slide deck. So I'd like to say thank you for giving me the opportunity. Thanks for working with me, Kevin. And additionally, this educational webinar was stimulated or supported by an educational grant by REST Event. So I thank them for for their support and the work they're doing to better understand cough and IPF. And so I'd like to thank everyone and look forward to our next educational series next month.
All right. Nice job, Dr. Cosgrove, and thank you everyone who attended the webinar.
Have a great day.